We're back with Dr. Kevin Connor, neurologist. Dr. Connor, we left off talking about treatment of stroke. If someone has a TIA and they ignore it, what's the chance that they're going to have a stroke?
So most people who have a TIA have a higher risk for developing stroke. And we know that within the first couple days, actually having had that TIA, that's a warning sign that a big stroke may actually happen. Generally within that first month is a real critical window, but that first 1 to 2 days is really the critical aspect of that. And at TIA, there are things we can do to help prevent stroke, and with that little bit of a warning, you got lucky. So now's the time to figure out why, and now's the time to intervene to make sure that we can prevent something permanent from developing.
Well, I'm a guy. I have a TIA. Being a typical guy, I ignore it. What's the odds that I'm going to have a stroke?
The odds of you going to have a stroke after a TIA is about 5 to 7% in the next year or so. Okay, the majority of that odds is within that first 1 to 2 days, and it's actually fairly high at that point.
Getting back to treatment of strokes, we mentioned there's two types. There's thrombotic, where the blood vessel occludes, and there's the hemorrhagic, where there's bleeding in the brain. So when you show up in the emergency room and they diagnose you with a stroke, which of the patients can you give TPA, the agent that lyses or breaks up the clot, and which ones can't you?
And so that's the beauty of the CT scan, is it shows blood. So if you've got blood in the brain, you're not a candidate. You don't want to do a blood thinner if you've already got blood in the brain. If you're the ischemic stroke, the one that has the pipe basically plugged up, then that's the patient that can get the TPA.
And how quickly do you need to get the TPA on board?
We try to get TPA within 1 hour after confirming of his stroke and getting all the imaging stuff done, basically.
So is it an hour from the time you've had the stroke to the time you get the TPA, or is it from the time you hit the door?
It's from the certain criteria. There is now door to needle time is what we're looking at, and we're trying to shore that down. The bottom line is the fastest way we can do it is what we need to do, because the longer you wait, the more brain tissue you end up losing.
And is there a period of time after which it's too dangerous to use the TPA?
Yes, the TPA is a blood thinner, and so it can create a hemorrhagic stroke as a result of that. We know early on the risks are low. Once you get it past about 4.5 hours of doing TPA, the risk of hemorrhage goes up astronomically, and that increases the mortality rate associated with stroke once you bleed.
And how good is the treatment? How successful is TPA?
It's more successful than sitting there and doing nothing. And so it's not 100% by any stretch of the imagination. I can say that since I started practicing, we didn't have that initially, and now we have that initially, and we do see successes, and pretty dramatic successes, sometimes things that reverse to 100% on a pretty good regular basis.
And what's the risk of using TPA?
The risk of TPA, a blood thinner, and so the risk is that you create hemorrhage. So there are criteria that we use that exclude you from getting it. So if you had recent surgery, you don't want to give somebody a blood thinner if that was the case. If you had a recent brain hemorrhage, you don't want to give somebody TPA in that setting as well. So there is risk of bleeding, and it's about 7 to 10% in the best of circumstances, even after excluding some of those patients.
So then you convert a thrombotic stroke to a hemorrhagic stroke.
Correct.
In that instance.
Yes.
And the treatment of hemorrhagic stroke, you got to call me.
You do. You got to call a neurosurgeon.
And I spent many years taking care of hemorrhagic strokes.
And crack a skull. Exactly
hemorrhagic
right.
stroke.
So.
Now, how often do you need to do surgery in a hemorrhagic stroke? Certainly not all patients require surgery.
They're not. And the age of the patient and the health of the patient really determines a lot now as to who you go in and do surgery on with a hemorrhagic stroke than it used to. We do know that the hemorrhagic strokes are far more fatal, and the outcome is far worse when you have a hemorrhagic stroke.
Now, what is the prognosis for a patient with stroke?
It's all over the map. So it really depends upon where the stroke was, and it depends upon how severe the stroke was. And so some patients 100% recovery, some patients get absolutely nothing back, and it could be anywhere in between.
And how often do you see 100% recovery? Is that common or is that rare?
It is fairly common. It is now. I mean, you do see it fairly commonly, and most importantly, we can we can prevent a second one from occurring. And so that's the good part about it as well.
Well, brings us to our next topic. How do you prevent a stroke?
So stroke prevention, when somebody comes in with a stroke, we look at several things. There are blood factors that can cause stroke, and so we address those blood factors. So things can make your blood clot when it's not supposed to. Biggest risk factors are cholesterol. And so obviously getting that cholesterol down is really, really key. Blood pressure is another really huge key as far as prevention of stroke. Diabetes is something else that's out there. Tobacco, those are the really big risk factors that we see in regards to stroke prevention. And then there's medicines that we can use that try to prevent you from forming clots down the road. Or we can look at your carotids, and if your carotids are all clogged up, if they're 70% or greater, we know that if you go in and clean them out, you do better than if you just ignore them and leave them alone.
Now, at what point, speaking of carotid disease, at what point do your carotid arteries need to be cleaned out?
So the magic number, and that's been looked at in several different studies that have been out there, is 70%. So if they're 70% or greater, we do better, and we do 21% better than if we just try to manage it medically.
Well, say you find the patient never had a stroke. You do a carotid ultrasound. You find 7% constriction of the artery. Do you do surgery on that patient, or not?
Usually, no. And so an asymptomatic carotid stenosis, typically we will treat that medically, but a lot depends upon who you see. So if you see the vascular surgeon first, you're more likely to get your carotid done than if you see the neurologist or your internist first. But it's always worthwhile following that, making sure it's not progressing, but getting very, very aggressive with the risk factors.
Do you go on blood thinners in that instance?
I put patients on blood thinner in that instance. And cholesterol-lowering medicines stabilize plaque, and so it's another way to try to prevent strokes from developing. Really key, getting blood pressure control and addressing all those risk factors.
Now, of the blood thinners, which do you prefer?
That's a hard question. It seems like it would be really, really easy. We know that with atrial fibrillation, which is a funny heart rhythm that people will get where they actually throw clots off, blood thinners like Coumadin, blood thinners like you've seen the ads for Xarelto and Eliquis and all that, do better than what we call antiplatelet therapies. Aspirin, Plavix, and Agranox are the ones we use there. So in that circumstance, I think the information's out there very, very well. First stroke, first TIA type symptoms, generally an aspirin a day is effective for most patients.
Now, warfarin, how common is bleeding, unexpected bleeding, in areas that you don't want bleeding with some of these blood thinners, like warfarin or Plavix?
They can be fairly common. Plavix less so, warfarin without a doubt. It's a dangerous drug. You have to regulate it, you have to respect it, you have to know about drug interactions because a lot of things affect blood thinners.
Yeah, I remember a case that I took care of. It was a man that was on Plavix, warfarin, and aspirin, and he had a giant bleed in his spinal cord. So blood thinners can be dangerous.
They can be dangerous, so.
Dr. Carter, thank you for joining us on the show. That's all the time we have. We have to wrap it up, and we'll see you all next week.